Hello dear friends, welcome back to my YouTube channel. So in this video we are going to cover the FMGE recall questions related to dermatology which were asked on January 17th, 2026 examination. And yes, no doubt these are recall based, so there will be some differences in the question actually asked in the exam and also in the options. You can put any differences in the comment section, and please watch this video till the end because the MCQs are very important from the upcoming exam point of view. Okay, these were all the topics from which the derma questions were asked, and if you see carefully you can observe that the sexually transmitted disorders, from this topic there were 3 questions. So it is a very important topic for all of you. And also if you see carefully, there are so many questions related to infections. So infections, that is also very important, right? This question also. And students told me that there was no MCQ related to scabies, so we can remove that, right? So right, chalo, these were the questions. So starting with this female presenting with vesicular lesions on the upper lip, okay, and it was mentioned that there were target lesions which are present on the extremities on examination. So what is the most likely diagnosis? So most probably these vesiculobullous lesions which are present on the lip, they are herpes labialis because of the HSV infection. And all of you know that yes, the HSV infection can produce the erythema multiforme which will present with the target lesion present over the extremities, right? So answer here is going to be option B, erythema multiforme. Chalo. Next is the 40-year-old truck driver, a person going to Thailand. Most likely these are the clues given by the examiner for STD related questions, right? And also it is mentioned that there was a history of sexual intercourse with sex worker presenting with single painless ulcer in the oral cavity, and that too at the corners of the mouth, right? And there was a painless ulcer on the penis. So what is the most likely diagnosis? This is a question, and I hope all of you do remember the painless genital ulcer can be produced because of primary syphilis, right? And the reason for the lesion in the mouth, it is a extragenital chancre, for which the most common site is the mucosa, oral mucosa. It could be over the lips, it could be over the tongue, right? So that is because of the oral sexual practices, right? Chalo. Next is this question. Yeah, this is a repeated n number of times, and by this time I hope you have marked by looking at these clues, that is there is GST present, granules are present, there is sinuses present, there is tumor like swelling which is present, okay, and from that the granules which are coming are black granules, and there were also hyphae which were mentioned in the question. So this is the diagnosis is eumycetoma. So the examiner is asking you next level of the question now. You need to know what is the treatment for eumycetoma. So in eumycetoma, the causative organism is, yes, it is a fungal, right? So antifungal we can use, and remember this is going to be treated with antifungal and also surgical debridement initially. If the condition is refractive for antifungals and surgical debridement, then only we will think of the amputation. Otherwise first we are going to go with the medication treatment. Conservative will try to treat it, okay. So some students, they thought that this is gross infection, so we'll amputate it. No, that's not the case. First we'll always try the medical treatment, conservative traditional methods, then we'll go for the amputation. So next, coming to the another STD, individual age 27 years, there is a transient genital lesion which resolves spontaneously, and 2 weeks later there is fever and painful bubo developing in the inguinal lymph node area, right? So the chlamydia trachomatis is a causative organism which is already given in the question. The examiner is asking you what are the serovars responsible for this infection. Again, this question is also a multi-layered approach related question. So first you need to know what is the diagnosis. So how can you come to the diagnosis? So in the sexually transmitted disorders, there is only one condition which is very peculiar in producing transient genital lesion. What is that condition? Yes, so just like RGV, who is very different, LGV is that disease where there will be very transient genital lesion. And also yes, in LGV we can see the bubo. In LGV we can see the bubo. So diagnosis is LGV. So the causative organism, yes, it is Chlamydia trachomatis. So what are the serovers? So LGV, lymphogranuloma venereum. So the involvement of the lymphatics is very important. So the serovers are going to be L1, L2, L3. Okay, so this is how you can answer these questions. Multi-level approach is required definitely. One question for all of you, you can put it in the comment section. What is the other STD which can present with inguinal buboes? So if you know the answer, put it in the comment section. Next, yes, this is also a repeated question, very important. BT leprosy patient on MDT now developing inflammation of the pre-existing skin lesions, right? So what do you think of this? Is a lepra reaction. It is a acute inflammation occurring in a chronic infectious condition. Lepra reaction. Which lepra reaction is it type 1 or type 2? Yes, if you have guessed it, type 1 lepra reaction, you are absolutely correct. Type 1 lepra reaction, or in fact even if it is type 2 lepra reaction, in both of them what is going to be the treatment which you are going to give? Continue the MDT and start the steroids. That is going to be the management, which is best management strategy for lepra reactions, both type 1 and also type 2. So what is going to be the correct answer? Continue MDT, start prednisolone, option C. Right. Next is this pediatrics, microbiology, dermatology integrated question. So individual high grade fever lasting 3 days, there is a vesicular rash which is predominantly present over the trunk, that is centripetal distribution, right? What is the most likely diagnosis? And some students told me that this rash was showing the pleomorphic nature, with some lesions being fluid filled, some being papule, some being vesicles, some being pustules, so something like that. Okay, so by all these clues you can easily think of chickenpox, varicella as the answer. Very important topic, asked so many times. And in fact the rash, it can show characteristic of dewdrop on rose petal appearance also, right? Sure. Next, again a STD question. Painful genital ulcer, and there is ragged edges and there is tender inguinal lymphadenopathy. What is the most likely causative organism? So this was the question which was asked. And which STDs can present with painful genital ulcer and painful inguinal lymphadenopathy? It could be herpes genitalis or it could be chancroid, right? So here it is mentioned that the ulcer is having a ragged edges. So this is characteristic, and also it could be mentioned undermined edges. So we are not sure about this. Please put in the comments what was actually given in the question. So in either of the case, ragged edges, undermined edges, it is very characteristic of chancroid. Okay, so that is step number 1, coming to the diagnosis, which is chancroid. Now you need to answer what is the causative organism of chancroid. So if you remember, we have discussed it in the class, a crow which is crying. So that will help you to remember chancroid related findings. So many of them we have seen with the help of this short story. So one among them is the crow was crying. Why is it crying? Because the causative organism is Haemophilus do cry. Haemophilus do cry, right? So what are the other causative organisms? Klebsiella or Calimactobacter granulomatis associated with donovanosis. Treponema, you all know, it is syphilis. And Chlamydia trachomatis, just now we have discussed, it is the LGB. Right? Next MCQ says individual with a known history of rheumatoid arthritis develops a rapidly progressive painful ulcer over the leg, and it was having undermined margins, and there was violaceous border of the ulcer. And the image is also mentioned, given, it is showing the ulcer is present over the lower extremities legs. So with all these clues, what is the most likely diagnosis? So remember, there is a pyoderma gangrenosum, which is a neutrophilic dermatosis, which will present classically associated with inflammatory bowel disease, Crohn's disease, ulcerative colitis, or rheumatoid arthritis, and it will present with rapidly progressive painful ulcer with violaceous borders, mainly presenting over the legs. Very classical description. So answer is option B. But yes, I agree that this is not a FMG question. It is a NEET INICET level question. It was not asked previously in the FMG exam. Right. Next, a young child came for evaluation with scaly itchy rash, which is present on the face and also extensor surfaces of the extremities. And there is also a family history of asthma in the very close relative, that is a father. Based on this, what is the most likely diagnosis? Yes, so it is atopic dermatitis. If you remember, there is a criteria for the diagnosis of atopic dermatitis, which is called as Hanifin-Rajka criteria, which mentions that yes, itching is a very important major criteria, and the rash which is present classical sites, that is over the face and also over the extensor surfaces. And also one more major criteria is the asthma, history of atopic diathesis, that is asthma in the father. So all these clues are pointing towards a most likely diagnosis, which is the atopic dermatitis. Some students told me that, sir, there was a mention of nocturnal nighttime itching in this child, so why can't it be scabies? So that was what some students were telling, that nocturnal or night itching was mentioned. Okay, but in the question it is mentioned that face is involved, and remember, in scabies, infants are going to have the involvement of the face, but not the children. Okay, and also one more thing, why will the examiner give a history of asthma in the father if they want the answer to be scabies? So that also does not make sense. So that's why the better answer is going to be atopic dermatitis. Next is this, again I will say this is a previous NEET question, but not FMG. So my suggestion for all the students who are watching this, for the upcoming FMG exams, do the NEET PYQs also, at least, if not ANI, at least do NEET PYQs at least of 3, 4, 5 years if possible. So that the NB is the same body which is asking for NEET and also FMG. So probably they may pick some questions from the NEET and put in the FMG. So that's why better to complete NEET PYQs also. My suggestion, sincere request for all of you. So coming to the question of women with diabetes presenting with asymptomatic skin lesion. Okay, since 1 year, and what is the description? It is a non-scaly annular lesion. So what is the diagnosis? This is a question, and remember, there is this condition which is called as granuloma annulae, which will present with an annular lesion, especially over the dorsum of the hand, right? So now you may ask me, sir, how to differentiate from other options? Very easy, very easy. Tinea corporis, it is a fungal infection associated with itching and scaling, but both are not there in the question, so you can rule it out. Annular lichen planus, yes, lichen planus which is annular may present like this, but lichen planus will have itching, but here itching is absent, so it cannot be lichen planus. And obviously psoriasis is going to present with scaling, but it is mentioned it is non-scaly rash lesion. So at least by ruling out of the options you can come to the diagnosis. So that's why if you have overall good knowledge related to all the PYQs, you can at least mark the answer for some of the questions by ruling out of the options. So these were the dermatology questions. I hope these were the actual questions and also the options and the images. If you feel anything is different, so the links for my Telegram group and also WhatsApp group are there in the description. You can click that and you can join those groups. and you can tag me and ask me anything which is different from what was discussed in this class. And FMG students, my suggestion would be chill out for a few days, relax. Okay, so everything would have been great for you. You are going to get good results, and we are going to meet in the cerebral hum event. No doubt, we are going to rock the party. Till then, you can binge watch any episodes or any movies from all these platforms. But for the NEET and INICET students, the studies are going to continue even after this recall session. So please do continue that, and all very best. Myself, Dr. Maddineni Srinivas. If you find this video to be helpful, if you feel that the recall was very much similar to actual questions in the examination, please do hit that like button. Also do subscribe to this channel for more such awesome content on a regular basis. Thank you so much. Happy learning.